Welcome to This Week in Health IT. It's Tuesday News Day, where we look at the news which will impact health IT. Today, Drex Ford is in the house for a deep dive on contact tracing and a special extended edition only on YouTube. More on that in a moment. My name is Bill Russell, healthcare CIO coach and creator of This Week in Health IT, a set of podcasts, videos, collaboration events dedicated to developing the next generation of health leaders. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. They reached out to me to see how we might partner during this time, and that's how we've been able to support producing daily shows over the last couple of weeks. Special thanks to Sirius for supporting the show's efforts during the crisis. And I want to thank everyone who shot me a note last week. You're helping to shape the show. For those who didn't, just know that I want to hear from you. So please shoot me a note, Bill at thisweekinhealthit.com. Just answer the question. What's the biggest health IT question you have right now? And you either want me to talk to with a guest about or discuss on the show. And go ahead and send that over right now. I love hearing him. I did get a couple last week, and really appreciate them. Will Wieters sent me a nice note with some comments. Ed Mark sent me some comments, and others, and we're going to touch on some of those things today. So, and as I said, it's Tuesday News Day. Drex Ford is in the house to talk a little health IT news. How's it going, Drex?
Good. I love Will Wieters. Is he not one of like the smartest guys? I mean, I know he's just down the road here, and not to blow smoke up his skirt, but I like on Twitter. He's a good, insightful, smart guy.
He is
a good person. He's just a good dude.
He is absolutely, and his email was anything he writes is really insightful. But my audience is not as familiar with him as they should be because he has not been on the show yet.
Oh,
so this is an open invitation to Will. As you're listening to this, know that you have an open invitation. Anytime you want, we'll jump on. We'll talk whatever you want. Digital health. We'll talk innovation. We'll talk operations. Whatever you want to talk health IT. Open invitation.
Good. I like it.
All right. So people don't know this, but you and I have done our first joint consulting project, and it's always fun to work together.
Yeah, and, absolutely.
For us, a lot of our research is done right here on the show. We've done 50 plus episodes over the last 8 weeks, talking with all sorts of health systems, vendor partners, and others. And we put together a presentation based on what we've heard from the show, and then we mapped it out to what we think is coming next in healthcare and health IT. And I've personally shared that deck with my coaching clients, and we've given presentations to sales organizations and executives, and we're even going to talk to some product development teams here shortly. And what we're going to do today is a little different. Following the news segment, we're going to share just one section of the presentation we did, but it will only be at the end of the YouTube episode. So the podcast will end as it usually does, as my people like to tell me, about 5 minutes over what it should be. So at about 20, 25 minutes. But it will continue on the YouTube channel. And so if you want to see that snippet of the presentation that Drex and I are doing, you're going to have to go over to the YouTube channel, just scan through towards the end, and the show is going to continue. So, and while you're there, we're going to start doing some fun stuff on YouTube. So, we want everyone to subscribe so you don't miss a minute of it. Just head over there, click on subscribe, and you will be connected in. All right, let's get to the news. Drex, I love how smart you think I am. You sent me a 32-page document 90 minutes before the show and said, hey, let's cover this. And this is something you share on 3x Drex, and that's text Drex to 484848. And you can get those emails. But so we're going to go through this a little bit, and we're going to talk contact tracing. So the 32-page document is called Outpacing the Virus, Digital Response to Containing the Spread of COVID-19 While Mitigating Privacy Risks. You also sent a couple other stories.
There's a bunch of stuff. So I was Bill and I were talking before we started recording, and mostly the email that I get at Drex at 3x Drex is email from myself. As I read tons of stuff over the course of a week, I start to see things that I think are like, this is an interesting pattern, or that's a thing I need to learn more about, because there's just lots of stuff that the more I know about things, as with all of us, the more we know about things, the more we realize we don't know or understand about things. And so things like contact tracing, which seems to be super important in the how are we going to really get over the hump and stay over the hump until we have a vaccine or some other way of helping us get to herd immunity. One of the really important parts of this is contact tracing, which sounds sort of theoretically pretty simple until you get into it. And then you realize it's actually really, really complicated. Like if I asked you, who have you seen in the last 2 weeks? Bill, who have you seen in the last 2 weeks?
Yeah,
if we were contact tracing you now, maybe because you've been pretty much locked down, that would be a really small number.
Yeah, and it's interesting. This has been put out there as one of the core tenets to a solution, bipartisan. So everyone's saying, "Hey, contact tracing is a key part." We've seen it in South Korea work pretty effectively, and in Singapore, I think, or some other place. Well, China as well used it. But there's a lot of challenges. So let me tee up some of the stuff, because I love the fact that you sent this over, because I had the same thought of, I don't know enough about this topic. And so, just reading this stuff has really helped me. So here's the setup for it. So the virus is novel, which means there's no current defense for this version. Unlike the flu, where we have vaccines from year to year, this is novel. The virus has stealth transmission, incubation period of 14 days. The lethality of the virus is believed to be many times higher than seasonal flu. And the virus has a very high natural transmission rate. Contact tracing, fully manual, as you said, relies on a lot of workers to go through that information. And it relies on my memory, quite frankly. So, some of the options for contact tracing are fully manual, encrypted peer-to-peer protocol based on something like Bluetooth, and a location-based protocol. These are just some of the things that are highlighted in this story. I'm going to a couple more bullet points, then you and I are going to get into the conversation. So, okay. So again, relies on human memory. Manual contact tracing takes time, a lot of time, probably too much time. Manual, either that or just tons of people. So manual contact
takes
tracing,
tons of people.
Yeah, just you have to train, and just a lot of people, and it's been proven insufficient to contain COVID-19 on its own today. So up comes technology. It's more accurate, it's fast, it's low cost, and it's been proven to work. Taiwan, South Korea, and other places, which is pretty exciting. But then you get into some of the challenges with it. So privacy. So before we get into the privacy problem, let's talk about how this would work. So Bluetooth. Well, I don't know about you, but I don't have Bluetooth turned on my phone most of the time. So what are they proposing here?
Yeah, so in theory, and this is probably something that I'll post on 3X Drex this week too, there's actually a cool little MIT video that sort of describes in about 3 minutes how this works. But you would download an app, and it would use sort of the capabilities of your phone through and the Bluetooth capability to, as you walked around and did things, and if it saw other phones that had the app and the Bluetooth turned on, it would record that it had talked to that phone, that it had been in contact with that phone, and it would be able to say, I was in contact with that phone for like 5 minutes or 35 minutes or 20 seconds. Now you could build a protocol around that says, if you were only in contact with another phone for 20 seconds, maybe that's not enough to notify you if somebody comes up positive. But if you were there for 3 minutes or 4 minutes, maybe that's enough. And then basically what happens is that your phone, so it's a piece of data that's de-identified, goes into a big master database. And then if somebody comes up positive, they would say on their phone that they've come up positive for COVID-19. That would send a note to the database, and the database would look for all the phones that have been in close contact to you, and it would notify those phones, the owners of those phones, that somebody had been in contact with them probably around this date and probably for about this long. And that would then trigger what could be a lot of different responses, including a recommendation, if it was above a particular threshold, to get in touch with a public health person, or a public health person might actually try to reach out to you because of that. But you're right, a lot of this gets into privacy, right? How much information do you disclose? How much information does your phone disclose? Do you want to walk around with these apps on your phone? Would you use them if it's optional? There's a lot of people who won't do it. If it's optional, a lot of people who don't do it. Is it worth the effort? Is it sort of partially effective? And I think those are all things that I'm kind of learning about and trying to figure out now too. But there's a lot. Like I said in the beginning, it feels like it's probably a pretty simple thing, but when you start to sit down and just work through a single scenario of me talking to you about who have you been in contact with for the last 14 days, and then we rely on you to tell me who all those people were, including maybe a bunch of people that you didn't know, but you know that you did go to the grocery store on a particular day 3 days ago, and you were in the store for about this long. So there's a lot. Now we start with a lot of head scratching, like who else was in the store and which checkout did you go through? And did you take a cart or you didn't take a cart? There's a lot of other things that kind of come into this. It gets confusing really fast. And you talk to guys, I hear Mark Cuban on the air talking about things like maybe the human contact tracing program is a good way for the government to employ a bunch of people in the near term who are unemployed as contact tracers. But that also gets back to, you have to have some particular kinds of skills, and you have to be trained, and you have to know how to ask questions and all of that. So it's not easy to just turn somebody on as a contact tracer either.
Well, this is where Hollywood has done a good job of educating us on what the dystopian outcome could be, right? So Total Recall or Terminator, Skynet. This is the kind of stuff that this stuff starts with. This is where it gets complex, right? So I like this article because it or white paper really, because they talk about how much of the data actually stays on the phone, stays local, how it rotates the hashes so that it is almost impossible to de-identify. But they also talk about how laws should come alongside of this and make it essentially a federal crime to even attempt to de-identify this data. Mm-hmm, I mean, you have to protect the integrity of the people using this for the good of the community so that they don't, get tracked for some other reason down the road. And so that becomes, and this goes through that. It goes through hashing, storing locally. The centralized server, quite frankly, needs a bunch of information that it doesn't have in order to decrypt the location and the ID of the phone and those kind of things. But as they sort of piece this all back together, once you are COVID positive, it has a chain to go back and identify the people that you were around to give them the kind of warnings they need to know that they have been exposed.
The bottom line is, as hard as we can work to de-identify and make things very difficult to reassemble, there are people out there who are willing to work really, really hard to figure out how to undo the work that you've done to make things anonymous and de-identified. So, nothing is foolproof, and some of this ultimately just comes down to what's the right thing to do. And there's no solid single answer for that either. What's the right thing to do to try to cut the virus off at the pass? And so, yeah, it's definitely a tough one. Well, and there's also bills out there. There's a couple of bills that have been introduced about contact tracing and the data that's gathered for contact tracing and what it can be used for, and how long it can be retained, and what the disposal and destruction process has to be for it, and all of that. So there are definitely people in Congress who are thinking about all of those issues.
Well, and it's interesting because this article, again, doesn't shy away from that. You get down closer to the bottom, page 26, it starts talking about what groups like the ACLU have written and put together around this. Because during H1N1, they actually broached this subject back then. And let's see, previously the ACLU literature on the individual rights in times of pandemics, particularly white papers written during the H1N1 outbreak, focused on maintaining public trust in public health authorities and encouraging public cooperation in efforts to mitigate disease. It just goes, it has that, it has in defense of a freedom at a time of crisis. So it actually, it touches on the literature, and there's a fair amount of it that's been written around, okay, around the time of a pandemic, around the time of a crisis, what is the trade-off? And does the trade-off change for a period of time where it's, we give up some of our personal liberties in order to protect the greater good? And then as long as, I think a lot of us would do that, as long as we were assured that it would bounce back. Like it would not be an indefinite kind of program where they're tracking us all the time.
Right. And we've seen examples of, laws, regulations, rules that were created, specifically after 9/11 that continue to this day, that allow some pretty significant surveillance of the public and monitoring telephone conversations and other things that I think those are the kinds of things that have put a lot of people in this position of saying, once you lose those liberties, you never really are able to get them back. Like the government's never going to give, there's a lot of paranoia around it, which I understand, but I'm also with you that, I would be willing to give up some liberties for the good of the group if I knew that everything bounced back after the fact. It's just that part of it. How do you know it bounces back after the fact? That's
right. If you either have not watched any movies or you have no imagination, if there isn't a certain amount of skepticism on how this is going to be used. It's, for instance, Thailand. So you sent a couple articles, that one, that white paper, and we'll include them in the link. But the other one you sent was MIT Technology Review, and they had a list of all the contact tracing programs that are out there. And one of the examples was Thailand. So Thailand, National Broadcasting and Telecommunication Commissions provides a SIM card to every foreigner, just think of that, every foreigner and Thai who has traveled from countries that have been designated as high risk for COVID-19 infections at the time. China, Hong Kong, South Korea, Italy, Macau. I thought Macau was part of China, but I guess not. The app will track the phone's location position for 14 days and alert authorities if they leave the designated quarantine area. That's what we're afraid of, right?
Yeah, that's like a ankle bracelet or something, right? In some ways.
Yeah, it's
and then you go, what's the next step and the next step after that? Like once you start down the path, how far does it go? And are there things that are going on that you don't know about? Because we're all really, not all of us, I guess, but a lot of us are pretty suspicious about what's really going on in the background. So with our phones, we all laugh from time to time about how you talked about kitty litter and suddenly there's an ad for kitty litter on your Facebook page. And maybe that's just coincidental, or maybe there's something weird going on, but I think we're all a little paranoid right now.
Yeah, it's these are definitely interesting times. So that's contact tracing. It'll be interesting to see how we integrate into that data. And I'm glad you sent those articles over because it is something I've been trying to figure out. One of the articles I threw out a bunch of articles. I'm going to save that one for the end, but health systems must restart now to map out safe back to work strategies. This is Healthcare IT News article that was put out there, and it talks about just some of the challenges that we have in front of us. And I'm not going to go into the article too much because as I was reading the article, I was doing research on what health systems are doing. The most prominent being Atrium. Atrium has created their safe Atrium places to go, and they're encouraging people to come back to the hospital, and they're expanding their surgeries. And they've probably done the best job of integrating marketing and operations for creating that. But then I ran across University Hospitals Healthy Restart Playbook. And if you haven't seen this is worth looking at. It's University Hospital out of Cleveland. So uhhospitals.org, and they have Healthy Restart for the Community. It's phenomenal. So they have it's essentially a playbook for any business that wants to go back to work and what you should do for your employees. And it has a whole bunch of videos, keeping your employees safe, environmental safety in the workplace, building trust with your workforce, frequently asked questions. They have a UH Healthy Restart playbook. This is the kind of stuff it's really good. Just loaded with videos, loaded with bullet points on communicating with your customers and how to do that effectively. There's just so much in this that I was like, this is one of those things that we should, as either be borrowing or whatever. But isn't this the kind of stuff that people are saying? The information we want right now, and a health system is uniquely positioned to be that trusted source of information to say, okay, we're going to partner with the businesses in our local community to help them go back to work effectively.
Right.
Are you seeing more of this, or are these still pretty early on and isolated with UH and Atrium at this point?
I actually, I probably have about 8 or 10 of those articles that I've fished out of the news over the last 7 or 8 days, and it's everyone from health systems to companies like Salesforce who are talking about, here are the things you need to do to make sure that you're building trust in employees and customers to bring them back to your store or back to the office or whatever the case may be. And like you said, it's a lot of the stuff like you need to figure out deep cleaning. Like many of you have never really done that before, and now that needs to be a thing, and you need to talk about it and how it works. You got to have hand washing stations. You need to have gel. You need to maybe rethink how, if it's an office, how you lay out desks and how people travel up and down the aisles. And there's a lot of that stuff. But I'm with you, Bill. I think this is a real opportunity for health systems to show their leadership in their community as people who are public health and infection control experts, and they really can provide great coaching free services to other people in the community about, this is the way that you should behave, these are the things that you should do, because we're still in the middle of all of this, and this is your obligation. If you're going to open up, these are the things you need to do to help us make sure that we continue to flatten the curve. And there's a lot of stuff that it's not super expensive or really complicated. It just needs to be talked about by experts that you know and trust. And in most communities, the healthcare organizations are the organizations that are probably, when you look at the trust index in most communities, they are the organizations that communities trust more than anybody else.
Yeah, I'm looking at this section.
Take advantage of that.
Yeah, I'm looking at keeping your employees safe, and they have some of the things you were just rattling off. They have, but then they have a video. A physician standing next to the logo of University Hospitals, Cleveland Medical Center. Lab coat, purple tie, glasses, looking smart, and he's talking about what is an antibody test and who needs it. And then you go down a little further. I'm sure a physician in the lab coat as well. COVID-19, why we should wear masks. One on physical distancing and how we social distance in the workplace. And
those are short and sweet and easy to understand videos. They're the kinds of things that you could actually have your employees watch before they come back to work as part of their reentry program, right? I mean, to make them and the organization more comfortable. Yeah, so I love that UH is doing that. I think, I'm with you 100%. It's a great thing for healthcare organizations to, take the task of helping the rest of the community come back and be healthy and stay healthy and know what to do, know how to behave, because it's different from how we were behaving 3 months ago.
Yeah. Hey, I'm going to close with this question. The podcast with this question, which David Chow asked out on LinkedIn, and I thought it was a good question. It's an interesting question. and I've been asking people recently, I'm curious what your thought is. When will hospital revenue return to pre-COVID levels?
Oh, man, I mean, great question.
This is where you earn your money, Drex. Here.
Great question. So, I mean, I think even if we clicked on, right away and said, all the elective surgeries that we're doing, we're going to start doing those again, I don't think we could cram all those through the system in the new system that we've probably created, or the new system that we need to create, with all of the new screening processes and getting people to end process the way they do. People that we would test now that we didn't have a testing step in there before. All the PPE changes and swaps that we have now, which we talk about the consumption of all the PPE, but there's a big time factor in all of this too. I don't know if you've ever actually watched nurses or doctors pull this stuff off and then put it on again, but it doesn't happen in like a minute. It takes them a little bit of time, because it really is like a decon process that they're going through to make sure they're not contaminating anything else. So I think capacity has also shrunk, which means that we're going to have to probably think about how we do a lot of the stuff that we do today to become more efficient, so that we can eventually get back there. Yeah, man, when though? I don't know. Maybe we're a year away from being back to pre-COVID, revenue numbers, or even starting to get close and figuring out how we need to, color right up the line to be able to get back there. It's going to be a while.
Yeah, and I on his post, I answered Q3 2020, or I'm sorry, Q3 2021. And so that's not too far from what you're saying.
A little over a year, yeah.
But to be honest with you, there's part of me that says never. And the reason I say never is, we've known for quite some time that there's an awful lot of stuff we do as very precautionary. Putting people in a hospital, running a battery of tests, and some surgeries, and I don't know, just. We've just known that we err on the highly cautious side, and it generates an awful lot of revenue that, you go for a couple months without it. You change the model of care with the advent of telehealth and remote patient monitoring and other things. We may not see those revenue numbers again. That's the bad news. The good news is we've introduced some really efficient and lower cost ways of providing potentially the same level and quality of care for our communities.
I think too that if we think about the work we've done with telehealth and alternatives to coming to the hospital and going into the hospital, that really plays nicely into the transition from away from fee for service, right, to the models of pay right, exactly, pay us a fee and we'll make sure that you stay healthy. I mean, it's almost like there's did we get some wires crossed in the middle of all of this? I think there's a real opportunity to take advantage here now of some of the things that we've learned in the new model of healthcare. We just have to take advantage of it now.
Yeah, absolutely. All right. Well, that's all for the news section of this show. Special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, Health Lyrics, Pro Talent Advisors, for choosing to invest in developing the next generation of health leaders. This show is a production of This Week in Health IT. For more great content, check out the website, thisweekhealth.com, or our YouTube channel as well. If you want to support the show, best way to do that is share it with peers. Second best way is to subscribe to the YouTube channel. And if you want to catch the tail end of this show, please jump over to the YouTube channel right now to watch Drex and I talk about a business-centric IT approach to reopening. Thanks for listening. That's all for now. Well, that was all for now. Now we're on the YouTube portion of the show. I don't know how to do that transition. Maybe I should do another sound thing or whatever, but we won't do that. Drex, thanks again for taking a few more minutes to hang out with us. I appreciate it.
Of course.
I mean, we're going to get into this, but what's the one thing that's top of mind for you right now?
just in general?
Yeah, I mean, with this COVID thing and healthcare, what's top of mind?
We just came off this topic about how long before we get back to normal from a revenue perspective. And I continue to, have a lot of friends that work in small and mid-size health systems who are really struggling right now, burned through tons of days cash on hand, or at the point where they're really kind of hoping that government deposit happens tomorrow. I think it's going to change a lot of our rural healthcare situation, and I'm not totally convinced that it's for the better. So I worry about that. A lot of America is rural. A lot of them don't have many ICU rooms. The process that we've taken in all of this to shut down elective surgeries has really hurt a lot of them. And it's not just that it's hurt a lot of them. A lot of them have been, barely hanging on anyway. So anything was going to make them have a harder time financially than they were already having. So I worry about what's going to happen in small and mid-sized health systems, and are they going to continue to exist? Are they going to be absorbed by bigger health systems, or what's the story?
Yeah. And that's, I think, the same for me. I mean, what does business as usual look like? How much revenue has been lost permanently? These are some of the things that are, what's our new payer mix in our community? I don't think we can assume the payer mix of pre-COVID is the same payer mix coming out of this. It's interesting. And then the conversations I'm having in the, just the people, we had Mother's Day, so we have, the Zoom calls to talk to everybody in the family and whatnot. Just the conversations. We're getting to a point in our society and where there's a lot of finger pointing. So here I am in southwestern Florida, and they opened the beaches, and then somebody saw that they were crowding, and they closed all the beaches again. And you're creating this sort of, tattletale at the on the playground kind of thing, and it's not healthy. I don't know. I'm not recommending anything here, and we're not talking about health IT, but the culture right now is getting a little bit toxic for my liking. I think even on the family calls, you have different perspectives coming back and forth, and you get to see people getting upset, and it's hard.
I mean, it's a very judgmental situation. I mean, people want to see their family members who live just right across town, but they haven't seen them now for 2 months. The sun is out. They want to go for a walk. They want to drop by, and but to do that, sometimes there are other people. When you tell them, I'm gonna walk over and see my mom tomorrow, they get very judgmental about it. I'm not sure I would do that. I don't know.
Yeah.
That doesn't sound like a good idea, right? And then you start to second guess yourself, which maybe that's all good, but it is a little. You're right. There's a lot of judging of what everyone is doing right now, and some people are super judgy, and some people don't have good judgment at all. That's the problem, right?
All right. Well, as I said, Drex and I put together a presentation based on what we've heard on the show, and we mapped out what we think is coming next in healthcare and health IT. In this section of the presentation, we talk about navigating the financial challenge that is upon us, and as you were alluding to, and earlier in the presentation, we made the case that we're moving from one crisis to another. We're moving from a pandemic to a financial crisis in healthcare. And the question we were trying to answer is, how can a health system navigate out of the pandemic while mitigating the financial crisis? And, we're going to there's like 7 bullet points here, and we're going to talk about them. At the end of the day, to be honest with you, we had other slides in here. We talked about some mitigating factors. And if you had a bad balance sheet coming into this, you're struggling so hard right now just to keep your head above water that you're going to hear some of these things and go, how can we even do those things? I mean, we understand that every health system's really at a different point based on their balance sheet. And we made that point earlier. And the other thing I would say is we're really approaching this part of the deck from a health system perspective and not necessarily a health IT perspective. I'll just start throwing them out there. So for the first main action we have is restart your economy. And I'm talking about really restarting your health system's economy. And that means, people have to feel safe. They have to feel safe in your community. They have to feel safe going back to work. They have to feel safe coming back to the hospital. And, we need to make sure that we're squarely inserting ourselves in that conversation, not just the people who point out when we aren't acting appropriately. And at the latter part of the podcast, we talked about, the university health system, and you talked about a bunch of articles that you're going to highlight in 3X Drex. And that's part of what we have to lean into is, how are we helping the 7-Eleven to open up? How are we helping restaurants to open up, gas stations, grocery stores, whatever? And I know some of those are already open, but how are we helping them to open up? Because until we do, there's going to be a continued strain on our financials for the health system, because you can't, until the economy opens up, the health system economy doesn't open up.
Yeah. And trust, as you said, trust is a vital component to that. And the idea of having this playbook generated by a health system, it gives people a benchmark against which to judge whether or not they or others are doing the right thing. Somebody's got to set those benchmarks. Yep. Otherwise, people will invent whatever benchmark they want to invent. Maybe that's part of the challenge that we have right now, is that there's no authority that anyone is willing to listen to, because anyone who should be an authority seems to have abdicated a lot of that authority now. Yeah. So when you look at health systems, and as we talked about on the show, some of the most trusted organizations in any community is going to be your hospital or your health system. For them to be able to step into that gap and say, these are good things and these are bad things, you should do this and you probably shouldn't do this, gives everybody something to measure their own behavior against, which may be as much, if not more than, what everybody needs right now.
Yeah, and that's the second point is restoring trust in the health system. And the reality is, we shouldn't have anyone, governor, president, city council. These should not be the trusted authorities for healthcare in the country. It really should be Cleveland Clinic, Mayo Clinic. It should be the health systems in the local community who are helping to set the guidelines and helping people to understand the guidelines and helping people to understand the data moving forward. And one of the challenges is, we did a great job. We told people to stay away from the hospital. And you know what they're doing? They're staying away from the hospital. So we've got to turn that thing around and help them to understand when it's safe and expected to come into the hospital. And one of the points that you've made before, this is really a time for marketing to shine.
It is.
Let's get the message out. How do we get the message back out that, hey, we have some safe ways to engage with us?
Yeah. I think you think about being transparent and being as clear and easy to read as possible. And that is the chance to sort of talk about all the things you're doing to make sure that your hospital and your lobby is as safe as possible, that your exam rooms are as clean and as safe as possible. And that is just describing all the things that happen to make sure that they're clean and that they're disinfected, and that here's all the steps we're taking to make sure that we check you at the front door, that if we're valeting your cars, here's what we do to make sure that we keep your car clean. All that kind of stuff, all that information that you think people might just take for granted, that of course we're doing that, they don't take it for granted anymore. They want to know. They want to know what you're doing. And if you can tell them that, if you can be really clear with them, that boosts trust greatly.
Yep. That's what we saw in the Atrium example. So now we get to the point of, okay, they're trusting the hospital again, the economy's starting to go again, and now we're at this point of, okay, we have 2 months of revenue. How much of that is lost and how much of that can recapture? And so the third point is, you have to figure out a way to recapture lost revenue. And we've talked about the safe environment, but now it's, how do you identify all that stuff that was going on that really needs to be scheduled? Do you increase the number of hours in your OR, in your emergency centers and clinics? When are we ready to really push the throttle down and say, let's get as many people in as possible?
Yeah, I think that there's certainly a capacity issue, right? I'm married to a Canadian, and so many of my family members are Canadian now, and they were talking about how in the Canadian system there was already a backlog on elective surgeries, and now there's a really, really long backlog on elective surgeries. And the only way to resolve that is to increase capacity and make sure that you've got the throughput that you need to be able to drive that backlog down. But that requires more hours and more time and maybe more ORs, or at least more OR hours. And you do that by maybe doing weekends and other things. But you also have to be really careful, again, from the perspective of it only takes one, oh crap, to erase 1,000 attaboys. You have one, infection happen in an OR that becomes a big public story. All your trust is gone in the blink of an eye. So you have to be very thoughtful and very careful about all that. I think there are ways to increase capacity, and I think that that a lot of healthcare organizations will do that. As important as anything else is probably making sure that people who had elective surgery scheduled, that their elective surgery procedure doesn't turn into an emergency issue, right? So there are a lot of things that were just inconvenient and painful, hip or something, but at some point, it becomes like, no, this is no longer elective. This is a thing that has to happen. So you're going to have to do some triaging, I think, with those patients too, to make sure that the ones that really need to be treated get moved to the front of the line. And that may mean that other folks are going to have to wait, or as you increase capacity, you're going to be able to get them through. But I think it's a tricky conversation. It's going to be a lot of work for a lot of health systems to figure out who moves to the front of the line quickly and for what reason. What's the protocol? But if you have the rules and you talk about what the rules are, again, back to transparency, it's hard to argue with it.
All right, I'll take the one no one wants to talk about, which is reduce your cost structure. We tried to answer the question of when will we return to pre-COVID levels, and both of us are saying sometime next year. And I was talking to someone, and it was actually one of my clients, and I said, you should be modeling. Actually, probably should have been modeling from the day you stopped taking elective surgeries what the impact was on your revenue, and I'm sure they did. But they should also be modeling different run rates for, hey, let's assume it returns in Q4. Let's assume not till Q1, Q2, Q3. Modeling doesn't cost you anything. I mean, it's just somebody's time putting it on a spreadsheet, looking at the model, so that people can make a determination based on the facts and based on what their beliefs are. So those models, we had a phenomenal CFO at the health system where I was at, and she would have had like 5 iterations of different models on, like, even before this would have been a significant issue, and we would have been talking through those models from day one, because if our run rate going in was $6.5 billion, and our run rate all of a sudden drops to like a run rate of $4 billion, we don't need 19,000 employees.
What are we going to do?
Yeah, you've got to start fielding those questions. There's no magic bullet here. Everyone knows there's no magic bullet. We furloughed a lot of employees, 227 systems, I think at last count, have furloughed employees. This is going to impact budgets one way or another. So you might as well start to have the conversations now. Which projects are related to either reimbursements or related to cost savings? I think this is where soft dollar savings go out the window, and it's only hard dollar savings, and it's as immediate as possible on hard dollar savings. There's just no getting around it. You have to reduce the cost structure in some way, shape, or form.
It's one of my CFOs, and one of the best people that I ever worked with. I mean, they were Moneyball spectacular, analysts, right? They were always thinking about, here's plan B and plan C and plan D and plan E and plan F. If these things happened, here's what we would do. So there wasn't a lot of time sort of generating things from scratch when something went bad. It was always like, that's a plan B situation, and they would pull out plan C or plan F, and that's what we would do. Everybody, I mean, it was a great place to start, right? I think about my days in the military. We were always either in a crisis or we were planning for a crisis. And so you had lots of plans for lots of different crises. And when something happened, you had some plan that was kind of like the crisis that you were facing, and you at least knew where to start. And I think for most health systems, and when you look at IT shops, you got to think about it the same way. If we were asked to reduce by this much, what would we reduce? Part of that conversation has to be a regular conversation with your clinical and business partners, understanding that in a healthcare IT department, almost none of the stuff that you run because you want to run it, because it's good for you. You're running it for business or clinical partners. So if you're going to cut, you need to have conversations with business and clinical partners about, if we cut these people, that means we're no longer going to offer these services, or we're going to turn these applications off. And they need to be ready for that. You're part of that team. They're part of your team. You can't just say, we're going to keep doing what we're doing with half the people. That's not a recipe for success.
Right.
And that really goes across the board.
All right. We've got like 4 minutes to go. But the other thing I'll say on that is, and I won't go back, I won't say people negotiated poor contracts, although we did. But with this now in your head, think through this the next time you negotiate a contract. Think through, they easily scale up. Think of writing your contract so that they scale back down. They have to scale back down, because nobody anticipated this. And if your cost didn't change and your revenue dropped by, $500 million, then that's not a good contract.
Yeah.
So, wow, 4 minutes, 5 minutes. Capture government dollars was our next point. And, we talked about the telehealth. There's telehealth grants out there. There's remote patient monitoring grants out there. Are there any others that have come out since the last time we talked about this?
I don't think so. I mean, the only thing, we always worry about grants is that you get grant money and then you do a thing. And then at the end of that, take grant money as a way to kickstart something that you're actually going to be able to turn into a business line and is going to make money. Because when you take grant money just to do a pilot and there's no exit from the free grant money, that just disappoints everybody involved. So, think about that.
Yeah. The telehealth, I had to read this. So I read the telehealth thing that was in the Cures Act, or not the Cures Act, whatever the CARES funding. It is so broad. I mean,
almost anything.
Drive through that hole.
Telephone calls.
Exactly.
Yeah.
The sixth point we had on this was take advantage of disruption. One system's pain is another system's opportunity, really. So some systems aren't going to make it. What's your plan? You can look around at the market right now and determine who's going to struggle coming out of this. You can look at it as an opportunity for a strategic partnership. And if you know you're going to be one of the ones that struggle, you might want to reach out earlier. It's better to do those deals earlier on than it is when it's like, hey, if we don't get a deal, we have to, and this, if we're going to have to close our doors. But disruption, when you hear the word disruption, think opportunity. Disruption equals opportunity for someone. If things are changing rapidly, that's what happens. And then the last one, adapt to capture new reimbursement dollars. So this is where we talked about, and I'll let you close out here. We talked about the opportunity here. If CMS continues to fund telehealth and remote patient monitoring and the commercial payers follow suit, what's the opportunity here?
Yeah, I think there's a ton of great opportunity back to the other one, to disruption. There's a great opportunity here to do some things unlike any of the things you've done before. And don't be afraid of that. I think the other part of that too is, as you're in the middle of this and you made some decisions that you thought were really good decisions, and you find out that those are the decisions now in this situation that are eating your lunch, don't be super prideful about, no, that was my decision, so I'm going to keep doing it. Like, sometimes you just got to cut bait, right? You just got to let it go. That was a great decision at the time, but given the current circumstances, that isn't a thing that we should be pursuing. Don't be afraid to let that go. Adapt.
There you go. That's the last word. So restart your economy, restore trust, recapture lost revenue, reduce the cost structure, capture government dollars, take advantage of disruption, and adapt to capture new reimbursement dollars. So that's all we have for this show, the extended show. Drop me a note. Tell me if you like it, don't like it. Maybe we'll do it again. Bill at thisweekinhealthit.com. Drex, thanks again for coming on the show. Appreciate it.
Always happy to be here. See you all later.
Take care.